to the Pager podcast. I'm George Milner, and in this episode we are discussing everything relating to ECMO. Extracorporeal membrane oxygenation involves transfer of the blood to a circuit outside of the body, where it is oxygenated and CO2 is removed, before the blood is returned back again. Our guest today is an expert in just this and more. Dr. Alain Vuylsteke is a consultant in intensive care and cardiothoracic anaesthesia at Royal Papworth Hospital in Cambridge, UK. Dr. Vuylsteke is the clinical director of the Division of Surgery, Transplantation and Anaesthesia, and also the director of the ECMO service at Papworth, the largest specialist cardiothoracic centre in the UK. The physiology of ECMO circuits is fascinating in its own right and would merit a podcast itself, although we don't spend very long discussing it today. We start off by talking a bit about the development of the ECMO programme at Papworth and where it is today, before turning our attention to the evidence base relating to the technology. This brings us into murky territory discussing the challenges of research in the ICU and assessing ECMO in general, and variation in practice across different centres, not only relating to ECMO, but also in other areas of medicine. We also discuss how patients are assessed when considering ECMO, timing of initiation of therapy, patient transfers and logistics, and how ECMO is evolving over time. Naturally, we cannot avoid talking about the pandemic too, and the expansion of ECMO programmes in response. And finally, we get into some rather difficult questions regarding the transition of patients off ECMO and the increasing ability of intensive care units to support numerous organ systems simultaneously, though at what precise cost. As ever, if you like this podcast, then do share it widely, subscribe and give us a rating on Spotify or Apple Podcasts. It really means a lot, so we hope you enjoy the episode. Dr. Vuylsteke, thank you so much for joining me. It's a pleasure to be speaking with you on the podcast.
It's a pleasure to speak to you, George.
So you are the director of the ECMO programme at Papworth, and I was wondering, to kick us off, if you could tell me a bit about how this programme has developed over time.
Some of the patients I've been looking after, one of the services I helped to develop years ago, is called the Pulmonary and Arthrectomy service. It's a very, very precise and specialist operation that only happen in a few centres in the world, and it happens that Papworth is the leading centre with the greatest number of patients operated per year for that operation. We do around 150 of those patients who come to us with a progressive narrowing of their pulmonary circulation. So over the years, their pulmonary circulations will change. I will not go into the details, but progressively get obstructed, and for that reason, they become short of breath. Their life expectancy is massively shortened, and the only way to treat it is to reopen the pulmonary circulation. This is done through a complex intervention that requires a lot of steps, but at the end lead to the lungs, the parenchyma, to suddenly be reperfused after many months or many years of chronic ischemia. And when that happens, you have what we call, probably wrongly, but we like to call it that way clinically, a reperfusion injury that leads to acute pulmonary edema and the inability to gas exchange. So involved in that probably 20 years ago, and making progress in the development of the service and having better and better success, we were frustrated that we could not really turn around, or use better word, save patients who had an intractable, very severe acute pulmonary edema postoperatively or intraoperatively. And we looked at solution. And one of the solutions was to continue the cardiopulmonary bypass that we used during the intervention, or to try to apply extracorporeal membrane oxygenation to turn those patients around. So in 2006, with one of my surgical colleagues, David Jenkins, who is the lead surgeon in the program, we set off to go to see how other people had been successful in using ECMO in other situations, clinical situations, and try to import it in our center to make it work, and make it work specifically for those patients. I mean, before that, Papworth had used ECMO as a adult leading cardiothoracic center, but our outcomes were not good at all, and we could not understand why. So we went to Leicester, who at the time was the best, or was considered as the key center in Europe in relations to using ECMO for respiratory failure. And then we went to La Pitié in Paris, who had quite a good experience of using ECMO to support patients with cardiac problems. So we then merged the expertise and experience that these two centers had acquired and brought it back to Papworth, and then developed what is now the ECMO service. We were lucky at the time when we went to visit those centers that technology had moved on and new pumps had started to appear on the market that were allowing to push the blood around the ECMO circuit with less trauma, less damage, i.e. the blood will not be squashed, the red cells will not be exploded by some sort of pressure. It was the innovations, the arrival of the centrifugal pump that we had already used for our artificial heart system, or artificial heart or ventricular assist device program. So we had some experience with them. So we then introduced ECMO in Papworth in 2006, came back specifically to support those patients with who had been operated on with the pulmonary and arthrectomies. It took us 2-3 years to get it where we wanted to be. Trial and errors, it was working okay, but we were making it to work better and better. One of the key elements in ECMO service is to get the staff to look after your patients 24-hour days, 7 days a week. So we started to train all the specialists we needed, many our nurses, started to get them to understand the system, help us to make it better, help us to make it in a way that they could look after the patient all day long, that they could wake the patient up, that they could mobilize the patients, that all sorts of things could be done despite the patients being on ECMO. And we did that. And by around 2009, we had a system that was working quite well. We were happy with the way we were using the technology that was in use in many other places in the world. But we thought that we had a good level of local expertise for the indications we needed. At the same time, in 2009, another pandemic hit us with H1N1. And that led to patients suffering very severe respiratory failure that we knew would be reversible if we could support those patients at the worst of the respiratory time they were going through. So we then suggested that we could come and help Leicester and maybe others to provide ECMO for patients with H1N1, for the most severe patients with H1N1. And we were indeed asked to support the national response at the time, and so started to do much more or many more ECMOs in patients with acute reversible respiratory failure in the context of infection. That proved to be successful. I mean, that was published, that was reported. A lot of people were very interested. They thought that it was certainly something that had to be available, and we needed it in the NHS to offer it to the sickest respiratory failure patient. And in 2011, the NHS indeed decided to set up a national service to provide ECMO to any patients who would need it in England. And when I say ECMO, is to provide ECMO in the context of respiratory failure. So in 2011, the NHS asked expression of interest for whoever wanted to provide the service, and centers put their hands up. We were one of them. We were then selected with 4 other centers, and we were asked to set up a national network, national service that would provide respiratory ECMO, as we call it, for any patients in England from that point on. So that was the start of the service.
Fantastic. And fast forward to now, how many patients roughly in the country receive therapy using ECMO over a normal year, the pandemic aside?
Okay, pandemic aside, what we've seen since 2011 to just before the pandemic, it's a steady increase in the number of patients referred by ECMO, certainly a steep increase for the first few years, and then a smaller one over the last 3 to 4 years. But overall, the number of patients supported in England, so not including Wales or Scotland, because as you know, the systems are different. We were providing before the pandemic around 250, 300 patients were supported per year. So providing for 250 to 300 patients per annum altogether. I mean, my numbers are quite approximate, but it's the sort of figure you're talking about.
But if we compare that to the number of patients receiving ventilatory support in intensive care units across the country, it's a tiny fraction of that number. So I guess leading on from this, how do you go about selecting which patients are appropriate for this service?
Okay, that's an excellent question and an excellent observation. Indeed, ECMO for respiratory failure is only offered to a very small proportion of patients who are ventilated for the same reason. And why is it? There are multiple reasons, but I would say that the first one is that nobody knows yet if ECMO makes really a difference to the population. Nobody has ever proven that ECMO is better than conventional therapy in relation to reversible severe respiratory failure. There's been multiple trials done over the years. There's been several RCTs. The first two randomized control trials that were done years and years ago didn't show a benefit for ECMO. In fact, they showed the reverse. It was more dangerous to go on ECMO than not to go on it. And this was probably because of the way ECMO was applied, the risk of bleeding, of thrombosis, issue with coagulation, but also the fact that the ventilation was not very well understood, and patients were probably ventilated the wrong way even when they were put on ECMO. Later on, there was a trial that came out at the start of the H1N1 pandemic called the CESAR trial, where patients had been randomized in England to either remain in their own hospital or to be transferred to Leicester for consideration of ECMO. And that trial showed that it was beneficial for patients to go to Leicester, but that trial failed to demonstrate that it was because of ECMO that it was beneficial to be transferred to Leicester. And then the last trial was the trial published by mainly the French and some Canadian called the Aeolia trial that came out in the New England in 2018, I think. That again was the best, largest randomized control trial on the topic. And in that trial, they failed to show a differences between the two. There was a lot of controversy because the trial was stopped too early was stopped early. We all say probably too early by the data safety board for a reason of the preliminary data they were looking at. But clearly that trial didn't end up showing that ECMO was better than conventional therapy. ECMO enthusiasts have tried to change the interpretation. You can always do that on any trial by redoing the statistics, by adding the clinical viewpoint. And when they had that and we redo the stats, we can all then say, yes, ECMO is better, but you know better than me. This is not proper statistical approach to a problem. And so the questions remain, are the clinicians correct to use it? Statistically, scientifically, we have not demonstrated that yet.
Alarm bells ring whenever you hear kind of post hoc analyses being substituted for the original intentions of a trial. My question leading on from this relates to ECMO is, as you've mentioned before, it's something that requires an entire team 24/7, specialist facilities, specially trained clinicians as well. How do you perhaps differentiate between, and I know you mentioned Leicester in particular there, perhaps differences across different centres that are offering it, and in these sorts of trials, make sure that it's standardised to the extent that you can make an overall judgment as to its efficacy?
Okay, I mean, in terms of the way we can look at the efficacy before answering your question is indeed either by randomized control trial, like the Aeolia trial being the last one. And as you know, in those trials, all the criteria will be set up very rigidly by the protocol. So entry criteria, the type of patients that you can take in the trial and then randomize to the intervention or not will be highly defined, and that then allows proper comparison. If you go on to the trying to observe what we are doing and see if it is working, you're indeed encountering the problem you're probably alluding to, is that everybody does it a bit differently. And the criteria to select someone to go on ECMO in Papworth will probably slightly different than the one in Leicester. And then if you pick Leicester, their criteria will probably be very different than the one used in Germany. And then if you go in Germany, probably that their criteria are not the same as in Japan. And off you go around the world and you find out that nobody is practicing it already the same way. And looking at what's going on, it's very, very difficult then to ascertain what is the benefit, and then also to try to find out what is happening to the patients who didn't get it, because there is a bias of selection. There is also a bias of data collection, in a sense that we usually forget to collect data about all the patients we decided not to go on with the ECMO, and therefore nobody knows what has happened to them. So that's a big issue in any intervention analysis, in the observation of clinical intervention, is that people often don't know what's been happening to the one who were not selected for that intervention. So one of the things that we've done in England since the start of the service in 2011 is we've made the centers work very closely together. So we meet several times a year to discuss our practice, to discuss how we select patients. We've agreed on common selection criteria. It's probably the wrong term. It's more on the same criteria to discuss why a patient has been taken or not. And then by doing so, you start to unify practice, and people start to do more or less the same. But I mean, you know that to have two clinicians doing exactly the same is very, very difficult when there's no good evidence base to support what needs to be done. Do I answer your questions a little bit, or make sense?
No,
you can ask me more questions if you want, for sure.
Definitely. I would like to actually focus on this, and I think it links into the overall challenges perhaps within research in ICU, where you're faced with potentially a very heterogeneous patient population. I'll contrast. I was doing a small literature review today looking at asthma presentations in children, where there are perhaps many more standardized kind of approaches to grading severity. There are a vast number of children who present to the emergency department each year with that. Is it fair to say perhaps we have the opposite here, where we have a smaller number of patients with perhaps a much wider kind of number of potentially comorbidities and parameters that you could consider in selecting somebody for ECMO? And does this make, I guess, randomized control trials more difficult in this setting, or am I barking up the wrong tree?
I think we're touching on the field you like, isn't it? We're going into data analysis and trials and how to do it best. And you're totally right that intensive care is probably one of the many very difficult fields in medicine to try to be able to run not only the randomized trials, but certainly the observational trials. Because there is so much variability and so much variation in the patients we are treating, variability in the conditions that patients go to intensive care for, variability of the barrier or how the patients have to be to come to intensive care. Admissions criteria to intensive care will be variable from hospital to hospital. Some clinicians will think differently. If you go from region to region and the country to country and continent from continent, you're talking about totally different type of patients. So that's making any observational or prospective studies very, very difficult. The other thing you have as well is that a lot of what is done in intensive care is not based on any evidence. I mean, years ago, I ran a survey. Interestingly, it was the year the iPad came out. So when I launched the survey, I offered an iPad to one of the participants, and I never had so much reply to any survey I've done in my life. Like every single clinician all over the globe wanted to answer the questions I'd set out, just because there was this iPad waiting there. And the question was, what Ionotropes do you use? What is your first choice, second choice, and third choice ionotrope in intensive care? And I had as many answers. There was clinicians on the trial. I remember doing the pie chart to show the distributions of the various combinations that could be. And I think I was running out of color to be able to show the differences, because every single person was giving me a different answer. Every single one was doing it differently. And then if I go back then to just Papworth, for example, if I was to ask the same questions to colleagues around me, asking, say, the top 3 inotropes and in what order they would mix them together to make things work, I would probably have as many answers as I've got clinicians, even if there is only 3 choices.
I was smiling in the middle of that because in fact, you won't believe it, I spoke with Dr. Nicola Jones at Papworth a few weeks ago, and I wanted to run exactly the same sort of survey. We genuinely talked about ionotropes and vasopressors because I'd seen there was quite a lot of variation in what people decided to use, and I wondered whether that was translated across the country. Anyway, that's ongoing, but obviously I've been a few years too late on asking that, but that's quite funny. And I think, yes, really does touch upon the fact that lots of things aren't necessarily done for clear randomized control trial evidence. And certainly I've seen certain things that clinicians in Papworth seem to just quite like a lot. And that seems to be the explanation for why they're used. Perhaps there's an expertise base within a certain centre, and therefore there are people that you can speak to about it. And that leads to a repetitive cycle and things are easily available. But it did strike me, certainly in my time on placement there.
Oh, in Papworth, you got the Papworth way. That's the only good way that we will tell to everybody to do things. But a lot of it is based on cooking and past history where we felt it worked. When we try to move away from it, we feel it doesn't work. So we think that our way is the only way to get there. It's only when you start to look at what others do and have the same or better results than you have, and they do it totally differently, that you realize that your way may at the end not be the best one, or sometimes that your way has been wrong for a very long time. In the last few years in intensive care, there's been a great effort in various over the world to try to increase the evidence base. I mean, the UK certainly is participating in that. There's been quite large, I would not say good, they were good, randomized control trial. It's very difficult to set up. People have gone all the way to set them up, to run them. The results are often been disappointed in the sense that most of them have come with no results, i.e. the null hypothesis is not disproven. So basically there is no difference between what you're comparing. The French have been excellent over the last few years to produce some evidence that is applicable in intensive care. I mean, for example, showing that proning patients with ARDS has a definite positive effect on their outcome. But there are indeed very, very few trials altogether. And incidentally, they're always on a very small number of patients, because when you start to apply exclusion criteria to try to get as homogeneous group as you can, you just end up by excluding nearly all the patients who are in intensive care at that time.
And certainly I think it's true that you can divide groups down until you have one person in each category and each treatment arm, which leaves you in a difficult position when you want to apply this to a very different particular patient in front of you. To provide some background, what sort of criteria do you use at Papworth for admitting somebody for support using ECMO?
Okay, you cannot go anywhere with ECMO, i.e. you're stuck in intensive care. So the only universal criteria is that it has to be, your condition has to be reversible, or there must be a solution to your problem. So if you think about respiratory, acute respiratory distress, the top criteria will be there must be a chance that that will just change, it will reverse, and your lungs will work again. Or exceptionally, you may one day become a lung transplant candidate, but that's not a solution to the problem, because transplant is only for very few. It's highly difficult to get there, but so it's reversibility. For cardiac patients, it's the same. Either your heart will recover, so you are in a very difficult phase, but it's reversible, or there are many other conditions met that means that the patient is a potential recipient for a mechanical support device, so the sort of artificial heart we use, or maybe for heart transplant. So the key criteria is reversibility. The other criteria are much more difficult to go through. First, there are quite a few of them. They are based on the evidence we just discussed, probably doesn't exist. So it's based on observation. We keep challenging them. We keep revisiting them. We keep pushing them around. And when I started ECMO, for example, we would never put any patients with cerebral hemorrhage on ECMO. While these days we can do that in again specific circumstances, but we can do it, and we do it, and we've got good success, i.e. patients recovering fully, not only from their lung viewpoint, but also from their cerebral viewpoint.
I take it that's for the anticoagulation reason.
The main issue when patients have cerebral hemorrhage is indeed that you you need to anticoagulate them to get the ECMO to run well. I mean, in fact, we've overcome that, so we don't need to anticoagulate all the time. We can take the risk not to do so. So the brain hemorrhage may not expand or be a problem. The other issue is that the ECMO circuit in itself, because of the blood passing to the plastic, to the pump, to the oxygenator, there will be an activation of the coagulation cascade. And that in itself could lead to spontaneous bleeding or extension of any existing hemorrhage or re-hemorrhage, etc.
I was wondering if you could expand on why waiting for a transplant or the potential of receiving a transplant in the future isn't necessarily this catch-all indication for perhaps a younger patient being put on ECMO.
Okay, I mean, there was someone years ago, and sadly I cannot remember who wrote that, but there was a quote. I think I can't remember which journal it was in, but someone said, for heart failure, for example, that transplantation for heart failure is the same that claiming that the lottery is the answer to poverty, i.e., in a sense, you will have many patients in heart failure requiring or who could be saved with a transplant, but you will only have a few of them who can be transplanted because of the availability of organs and all the chain that is required for it to happen. And also to remember that when you transplant the patients on the one hand, it means that another patient has died on the other hand. And with the progress of medicine and hopefully us doing well our job and getting people better, the pool of donors should be reducing constantly because we just keep improving on that side, i.e. decreasing the number of potential donors. So transplantation, as long as we don't have artificial organs sitting on a shelf, will not be the solutions to all the acute or chronic respiratory or cardiac failure. Then on top of that, you have to add that when you've got an acute problem, your physiology is so disturbed that usually you're not strong enough to sustain the insult caused by transplantation. The perioperative insult, the insult of the immunosuppression, the need to adapt to a new organ, etc., etc., etc. You're certainly not in the best condition to undergo that sort of challenge.
Yes, I think overall you do have to look at this and say that you must prove that the outcome of a patient who's been put onto ECMO with the intention of transplanting them is better than the outcome of the patient who could have otherwise received that organ who was not on ECMO previously.
That's another key problem indeed. And transplantation is distributive medicine as well. There are not enough organs to everybody. So the transplant physicians have to, in a way, it's a difficult word to use, and there are a lot of adjustment to make to that statement, but they have to rank just to give the best chance to look at it differently. What they need to do is to give the best chance to that organ that is available by putting it in someone who will carry it for a long time. So rather than to look at the patient's perspective, because you have to rank patients after patients and you always feel as a clinician very uncomfortable, it's the patients in front of you who is the most important at the time. So you should not have to rank that patient versus the patients behind the door. However, if you look at the organ from the organ perspective, you could say that you need to give to that organ the best chance to function for a very long time by putting them in the recipient that has the greatest potential to run with it.
Brilliant. I'd agree with that. Moving on slightly, perhaps timing is also an interesting topic to bring up here. I might start off perhaps by painting a picture in which, and you can correct me if I'm wrong, in which ECMO is used as obviously a therapy that's quite a long way down the line after a number of other things have potentially been attempted. To flip this around, to what extent could you say that by the time somebody has failed on a number of conventional therapies, would they have benefited from ECMO a lot earlier on? And perhaps is there a role for almost prophylactically engaging with these services before you've tried all the conventional therapies that might usually be tried before a patient is moved? That's not a very clear question, but I hope you get the gist.
No, it's very clear questions. It's a very good question, and I love the question because when you started ECMO, and I still think that it might be possible one day, if you take just about respiratory failure, because again, ECMO can be used in different circumstances, but let's assume that we only talk about respiratory failure to make it simpler.
Yeah. Okay.
We use mechanical ventilator. Why is it that we cannot use ECMO rather than a mechanical ventilator? You would not have to be sedated. You would not have to be anesthetized to get a tube in your throat and to have the mechanical ventilator pushing air in constantly, damaging your alveoli with the pressure. ECMO is a much more elegant solution than mechanical ventilation. Until you realize that ECMO comes with a lot of problem in its current state. As I've said, you need to anticoagulate the patient, increasing the risk of bleeding. Even if you don't anticoagulate, the fibrinolysis caused by the circuit itself will cause hemorrhage and all sorts of issues. Because of the way the gas are diffusing, you need to have a lot of blood going through the ECMO system to be able to oxygenate the patient. So the technicalities of ECMO are such, the complications related to the technicalities are such that it is not possible yet to replace ventilation with ECMO. If you look at the risk that you introduce into the patient, you got many more risk introduced when you use ECMO. And because of that, you then cannot start to use it universally because you will end up by harming more patients than you're probably saving by using it, if that makes sense.
Yes.
But my answer is probably as complex as your question. I don't know if it gives it, but that's the principle behind it.
I'm wondering if there is almost a catch-22 here. If by the time you qualify for ECMO, you're perhaps in the worst position to be receiving ECMO to begin with, because spending an extended period of time perhaps not responding to conventional therapies as well as you would hope somebody is going to, doesn't come without consequences itself.
You're correct. I mean, every time we assess if the patient should go on ECMO, we have to weigh the potential benefits that are not proven and the risk that we know well about at that specific time. So when you go along every day, when you ask yourself, would these patients benefit from ECMO, you will, for quite a long time, reject the idea because the risk of ECMO will be greater than the risk of conventional therapy. And when you do so, you don't know what tomorrow will be like. You don't know if the patient will still be unwell the next day, if the patient will not have responded to therapy while using conventional support. So you go on day after day, and then indeed at one point, it might be that suddenly it flips around, but by then the patient has gone too far. And even if you introduce ECMO support, they've got no chance to survive. We don't have anything that tells us for definite that our predictions, that our risk evaluation is absolutely accurate. And that's why the decisions to go on ECMO, certainly in Papworth, is always made by a lot of people together. When I say a lot, it's always minimum 2 experienced consultants, usually many more, and very often consultants from different specialties and different disciplines, because there is no such things as a guide, a book, a table, a software, a risk scoring, whatever, that tell us you're right or you're wrong. But you're totally correct that by waiting too long, we may just be missing a lot of the patients who might benefit from it. On the other hand, if we were to start it too early, we may start to harm many more patients who would have done very well without ECMO support at all.
And equally, if you had some sort of way of predicting the patients who were destined to fall into a 100% mortality group with conventional therapy, then that would almost there'd be no way for ECMO to reduce mortality in that group. It may not be effective in terms of a cost-beneficial analysis, but as you said before, we can't necessarily prove 100% that a patient does not have a chance of survival with conventional therapy, but can safely be transferred onto ECMO.
You're correct, and there's one key thing certainly to highlight in our discussions in terms of the word we're using. ECMO is just a support. It just supports the circulations in some configuration or the gas exchange in other configuration. It just supports. It doesn't treat anything. And ECMO success will be highly dependent on the success of treatment. That has nothing to do with ECMO. If you give ECMO to people who don't know how to treat, you're not going to get any benefit of it at all. ECMO will never treat on its own. The same mechanical ventilation doesn't treat. It does provide a support that indirectly may provide some benefit, but it's still not a treatment.
And we might talk a little bit later on about the future of ECMO and perhaps reducing the problems that you've discussed relating to anticoagulation and things like that. But I just perhaps like to stick with this for a little bit. And I know you've mentioned the entire kind of network and around the country, and I'm interested in the extent to which actually it must be very difficult to transfer patients who have met the criteria for ECMO given their physiological state. Could you talk a bit about that then?
I think it's the reverse. Because of ECMO, it's very easy to transfer them. So before the advent of ECMO, when you had to transfer a patient was failing conventional support, conventional mechanical ventilation, or cardiac failing because the ionotropes were not biting it anymore, to transfer those patients was really, sorry for the name, but sporty. I mean, you would be very busy during the transfer. You would have to keep adjusting things. You will never be sure that the patient will still be alive when you are arriving. You were always concerned in the absence of having a gas machine in the ambulance, or even sometimes being able to see the color of the patient correctly, that you were not causing a big hypoxic insult, or you didn't know if your CO2 was not in unrecoverable level by the time you are arriving at destination. With ECMO, all that has changed. What we do with the ECMO service, and that was the key difference that we introduced in 2011, is that we take the machine with us, or pipes with us. We go to the patient's bedside, reassess the patient, evaluate if we think that the support will give them time that will then allow reversibility of their condition. And then we just initiate ECMO at the referring site. And then when the patient is stabilized on ECMO, we can take all the time in the world to get them back to base. So we can go anywhere in the world to put someone on ECMO, and then could take a week to bring them back to us. During that week, they will be fine, pending we do all the other stuff that we need to do. Mm-hmm. So it has made the transfer much easier.
And that highlights a misunderstanding from my point of view. I was imagining patients having to be in a fit condition to be transferred to a centre for ECMO to be initiated, but
most patients we put on ECMO those days would not have made it alive to our centre if it was not for ECMO.
It would perhaps be the elephant in the corner that we haven't discussed so far is the use of ECMO during the pandemic. And would you be able to tell me a bit about how, I guess, the services you've offered and the patients you're treating have changed during this time?
Okay. I mean, a lot of things have happened. When the pandemic arrived, the only thing we really knew it was a respiratory disease, an acute respiratory disease. We knew from the start that ECMO would probably have a place to play. However, that's all what we knew. And still today, we know much more about the virus, but we still don't know. We still don't know enough, and we're still puzzled by the pathophysiology. And so we were thinking of using a support in a condition that we still don't understand fully. We didn't understand at the time, and we were not sure we would have treatment to give to those patients while being supported. And so we were not sure that those patients would the condition would be reversible with ECMO. The way we reacted to the start of the pandemic was first to observe what was happening in neighboring countries, think about Italy and others, who in fact reported that ECMO was probably not a solution to the problem at the time. We then looked at the capabilities we had in England and counted the machine, realized how many patients we could be supporting with it, acknowledging that it should only be reserved for the patients where we felt it would make a difference. So avoiding to make patients with no hope on it, because that would be not what medicine does. And also avoiding to give it to everybody who might do very well without it, because not only then you use a resource for the wrong purpose, but also you may start to harm people who don't need the device, and therefore you end up by causing morbidity and mortality that is not warranted to start with. So to try to do that at best, we set up very quickly, within a week, an electronic system across England that allowed every unit to refer any patients in England to the same portal. That would then be, that patient's referral would be looked at by one of the 5 ECMO centers, where you would have a lot of people working together who had acquired a lot of expertise or experience over the years, and then together decide if those patients, that specific patient, was a suitable candidate to be offered ECMO support, because there was a chance that there would be that the conditions would be reversible. So we set up, if you want, a unique point of entry for the whole country to allow us to look specifically at what was happening, and then also distill the information the other way back, i.e. telling people what we knew was making a difference in the patient's progress. So that's the way England responded. So being able to offer it to every single person who clinicians thought that they might get a benefit out of it. We then just went on and let's refer, so intensivists in the country, to refer patients they felt were in need of it, and then through multidisciplinary discussions in center, and then every day amongst all the centers, we then progressively decided which patients should go on or not go on, and then moved along during the pandemic. To facilitate discussions, we issued some criteria that was published and published on the NHS website that were not final criteria, but they were more a guide of, okay, when should you start to think of referring for ECMO? And then for us to have some sort of standardized way of talking about referrals that were made, so we could more quickly assess what we thought was the suitability or not. Does it give you a bit of an overview?
Definitely. One observation, I think I remember correctly, and I think still continues, is that patients with COVID-19 have often tended to deteriorate quite quickly. Did that change, I guess, and I don't know if that's in comparison to ARDS patients or from before, or in comparison to another group that I'm kind of confusing it with. But I was wondering, did you find that often you had to be very speedy in what you were doing?
Not really, because ECMO is not ECMO for respiratory failure is not an emergency; it's an urgency. So usually, what we do is that we just ensure that conventional means have all been used and exhausted before providing ECMO for what I mentioned before, the inherent risk of ECMO itself, where you could cause harm to patients without any proof that it is better than conventional therapy. So we don't really crash in. But it's true that at the start of the pandemic, we didn't know exactly what we were dealing with. So some patients may have deteriorated rapidly and our response may have been very rapid, but it was not the way or the way it was intended to be or the way it was set up. But one of the key things to realize about the pandemic from our perspective is that it has continued to evolve. Not only we got different variants, as you all very well know, but also the medical response has been evolving very quickly. Clinicians have been reacting differently. Intensivists have been applying different support, different actions. They've been proning their patients much more often. They've been using CPAP. They've been giving drugs. They've been changing what they were given. So for us, the patients have continuously changed during the last 2 years. And who we are dealing with today are definitely not the same patients as we were dealing with in March 2020. And they are not the same as the one we had, say, in April 2021. So there is a constant evolution. There's no stability yet. And the pool of patients being referred to us is different week on week because of all the other changes that are happening in the health system.
And in terms of the size of the pool of patients that you were assessing, I'm wondering, we saw perhaps reports earlier on the pandemic of perhaps intensive care units wary of admitting patients for fear of having to turn away patients at perhaps a later stage, maybe a week later, due to lack of availability of beds. I guess the question that I'm trying to get at is, was the decision to admit patients onto ECMO one of the number of beds you had on ECMO, or one based more on the projected clinical benefit for each individual patient, or perhaps a combination of the two?
So we're lucky that at no point from a clinical perspective, we had to curtail admission. We always had more beds available in the country than were needed. We were meeting every day, all the centers together. We were keeping a very, very close tally on the number of beds, but at no point did we reach maximum capacity. It is true that because of those meetings, there will have been an unconscious push into the selection and ensuring that the best patients, the best candidate, not the best patients, but the best candidate to recovery were selected. And some people may argue that that could have been a form of curtailing access by pushing the pressure from that angle. But I think most of us worked from a clinical perspective and every single time considered the patient in front of us and made the decision on the physiopathological value, i.e. what we were saying and what we were believing would be of benefit or not to that patient, and then looked for an ECMO bed. So there was no limitation. We were not told, you must stop, you must take less. It is not possible. We had a lot of pressure where people were concerned that we would take too many. But if you look the other way around, for every single patient, we took at the time what we thought, what we believe was the best decision based on what we knew. Looking back, we may just change a lot. We would probably revisit a lot of those decisions because more information, more insight, and also knowing what happened to the patients we've chosen. But going forward, every single time, we had no problem.
To what extent did the service, did the number of beds expand in the country?
A lot. So normal times, we got 15 ECMO beds in the country. That's the sort of baseline we go by. Every winter, we go up a little bit. We go up to 20 beds and so. And this year, we went well above 80 beds altogether. I mean, I'm very bad at the numbers, so don't ask me the precise figure. I could dig them out if you wanted.
No, that's okay.
But like just for Papworth, usually we get 3 ECMOs, 5. When we got 6, 7, it's a lot. And we went well above 20 and in no time. So the pressure on, it was incredible to see that our staff groups, the numbers and trying to look after a small number suddenly managed to duplicate themselves, triplicate, quadruplicate themselves, and look at so many patients so quickly. One of the interesting points about COVID, again, we don't really know the disease, or we don't know the disease yet or well enough to understand the trajectory. Patients supported with ECMO and COVID requires a very, very long run of ECMOs. So we've never had so many patients staying for so long on ECMO, and we've beaten all the duration records during the COVID pandemic by having patients staying on ECMO for well above 100 days before recovering.
And what would a typical value, or is there no typical?
Usually the duration of ECMO will probably, again, number is never my forte, but you could say around 15 days, 2 weeks, 3 weeks of ECMO. Complex cases, 3 weeks, sometimes 4 weeks, but most of them within 2 weeks, it's in and out, it's all fixed. When you talk about COVID, you need to at least double, if not more, that figure. So most of the patients, a lot of patients will stay well in excess of 60 days. Surprisingly, some of them will be extremely sick. And in fact, the COVID patients appears to be sicker than the others in terms of all what we need to do to them. It might just be because of our level of knowledge at the moment, but they appear to be sicker. They require much more support. They go on very sick, defying the limit of physiology day after day, night after night. And then suddenly, after 2 months or 3 months of support, within a few days, they just got better and say hello. And ECMO comes out, and then a week or 2 later, you see them on the ward and they are absolutely back to what they were before, or near to back to where they were before. So it's still extremely surprising. What we've done with COVID as well is to test the limit of physiology, as we had touched on before, but never done so harshly before. Running patients at PaO2 or physiological level that you would not even consider being possible as a physician, or given drugs, just support medications like sedation, sedative, anesthetic agent, in volume that you would not have conceived were possible to be delivered before, safely delivered before.
At a level that was so low, for oxygen partial pressure.
We have patients who've been sometimes for days on with a PO2 of 4 or 5 kilopascal, and would just recover fully after that.
In the ECMO department?
In the ECMO group, yeah.
Which, well, I might be missing a trick here, but why is it not possible? Surely ECMO is about increasing PaO2. Why is it not possible, therefore, to run them at a higher level? What's the logic behind that?
But why is it not possible? For multiple reasons. One of them is that to be able to increase the oxygen in the patient's blood, you need to decrease the oxygen consumption by the patient. And that's something we don't do with ECMO. We just add the blood in the system. We don't control what is happening to that oxygen when it goes in. The amount of oxygen we add to the patient is also limited by the blood flow that we can run through the pump. And that blood flow is then to be put in relation to the cardiac output of the patient. So if you have a patient with a very high cardiac output consuming a lot of oxygen, you would need to have a super high flow through your ECMO system to be able to oxygenate that patient at the level of the existing consumption. So there are a lot of physics rules and physiological rules that make it impossible. And surprisingly, when we put patients on ECMO, something people often do not realize is that we don't achieve as good oxygenation as what they had before going on ECMO. But the benefit we're getting is that we can decrease the harm introduced by other support mechanisms that have been, as we say, cranked up to try to control a patient's in free fall.
That makes sense, and I have all sorts of questions relating to therapeutic cooling and oxygen consumption, but I think that would be a bit much for for this podcast here. The question that doesn't actually come on from this, however, and it's a less physiological one, but or perhaps it does involve physiology, but is how you approach the transition of a patient off ECMO, and that could be a patient who is recovering or a patient who perhaps isn't recovering on ECMO. And I was wondering if you could talk a little bit about that.
Okay, so let's talk first about the patient recovering. When ECMO is a support, if the patient recovers, they don't need the support. So you can just liberate them from it. And often what we see is that if you take respiratory ECMO, when the patient is able to breathe and gas exchange to the lungs, you can just stop the ECMO. It's as simple as that. There is no such thing as exercising or weaning or taking it step by step. I would say simplified way, either you need it or you don't need it. I could put you on ECMO now and you will just be there and still doing the podcast. I can then just stop it and you will just continue to do the podcast. It won't change anything. So that's the process of removing it in patients who have recovered. In the patients who don't recover and where, for example, the lungs are destroyed to the point of no return, and there is no option for a transplant, and as I said, transplantation is will never be the universal solution, then sadly, we have to accept that those patients will not be able to stay on ECMO forever. It is not sustainable with life in the long term, because it does introduce with time more complications. Those complications will lead to more morbidity and eventually to mortality. It's also not probably, let's call it a life, to be lying in the bed with big pipes, not being able to do much, and be highly dependent on a machine connected to your body, connected to an intensive care in the back, because you cannot go home, you cannot go anywhere with that circuit. And knowing that at every single instance, complications could just take your life away. So when patients do not recover, ending the end of life is a very, very difficult situation. Most of the time, life will end because of complications of the ECMO circuits. Sometimes, exceptionally, discussions have to take place, often, and first of all, with the patient to see if what is it that they want to do, or do they want us to proceed from that point on? And people are usually then have to admit that there is nowhere to go. I mean, that's a very difficult topic to touch on and to discuss, because there are probably as many variation and differences from patient to patient group, ECMO group, clinicians. It is one of the downside of any mechanical support that we're using those days that is not portable, where patients cannot go anywhere with, and where they have a risk minute by minute of sudden death or extremely unpleasant complications.
So almost by extension, with improvements in ECMO technically such that complications are reduced, will that lead to more decisions having to be made regarding patients who are simply not recovering from the initial insult that put them onto ECMO?
You spot on. We are increasingly having patients being supported by ECMO, as we're discussing ECMO today, who end up in impossible situation. They are supported with a device, as I said, connected to intensive care, and there is nowhere for them to go. There is no future in front of them. And if we were to end up having the ideal ECMO circuit that will never cause, that never has any complication, that will just last there forever, we would rapidly end up with many patients stuck on it who have nowhere to go. And the ethical questions, the societal questions, the human questions will come out to say, is it right to do so? It's a problem that has not been fully answered yet. And it's a very interesting problem to raise because it is emerging in our extremely specialized field. We are facing it again and again. We are very not unsatisfied, but unsettled by it when it happens. So for every single patient ending up in that situation, it's a failure. We see that as a failure because we didn't select the right patient. We didn't give it to the person who would recover, or we failed treating them to the point of recovery, and we pushed them into that corner where what is next? Nobody has the answer. It's a very, very tricky question, and I'm probably the worst person to start to discuss ethics or anything related to it on the roof on a podcast in a Tuesday evening.
I mean, I suppose on the other hand, if every patient that you used ECMO for made a full recovery from it, there would probably logically be some patients that you'd declined from ECMO who would have made a full recovery. It's like saying if every appendix you take out is an inflamed appendix, then you're probably missing some other inflamed appendices.
That's correct. I mean, it's nice that you're comparing ECMO to appendices because but you just show that there are so many things we don't know. I like the comparison because yes, why don't we give ECMO to everybody? Why don't we take the appendix away from everybody? Do we miss too many patients where we haven't operated on and they end up with peritonitis? And do we miss too many patients we haven't put on ECMO and they die because we haven't put them on ECMO? We don't have the data, we don't have the figure. We are nowhere near, or we may be near, but certainly not from my perspective, we are nowhere near having enough data to give us the information we need to be able to progress in a sensible way. I think a lot of your questions reflect that we are all expecting, we all think that there are more answers out there than there really are. And that's the whole struggle of this podcast, where I've got the feeling we've gone a lot in circle and we've opened a lot of boxes and closed them quickly because there is no correct way to answer it, or just because I'm very bad at what I'm doing and I'm unable to articulate it properly.
I mean, part of this podcast is about asking interesting questions, even if we don't have the answers to them, and making comparisons. So I don't necessarily need an answer. I think you've answered them beautifully so far. So that's been great. I did want to talk briefly and say how much does ECMO cost overall? And it's difficult. Well, you can't necessarily do, as we've explored before, you can't necessarily do a cost-benefit analysis if you don't know what the benefits are to begin with. But perhaps we could talk a little bit about perhaps the ethical considerations that come from this perspective, and whether, even if, say, ECMO was proven to be clinically beneficial, could it be in, for example, the National Health Service, could rationing be introduced for a financial reason within this? And is this something that is considered currently within the ECMO service in the UK?
So ECMO costs a lot. Someone one day told me, why do you spend the money on one ECMO patient with cardiac failure in that situation, while the same amount of money could pay for an echo technician in the whatever city it was, and shorten the waiting time for my patients to have an echo after being started on an ACE inhibitor. So ECMO costs a lot. I mean, intensive care costs a lot. If you take the base cost of intensive care, you need to add on top of that the cost not only of the machines, the pipes are just plastic, but the expertise to look after that plastic. Your nurses, your senior nurses, your medics, your juniors, your pharmacist, your physiotherapist, your dietitian, everybody needs to know about it. So they use a huge indirect cost as well to the use of ECMO. So I will not put a figure on it, but it is very, very high. No, the return, some analyses have been done, and again, I know you're very good at that, and I will try to avoid further questions from you on that subject. But they've looked at cost benefit and realized that for patients supported with ECMO, because of the patients who are selected to go on it, i.e., the way the clinicians choose the patients who get the support, the patients surviving usually go back to a very good life. So the return to society and to the person first, and then to society is very big in terms of if you put a monetary value on it, and that probably knock off the cost of the technology itself. The thing, if the cost is in itself a reason not to offer it to some patient, I think it is a reason for us to try to calibrate and avoid to put it on patients who have no chance to recover from it, because that would just be wasting money. I don't think it comes in not offering it too early, because it would be too costly if we were to give it to too many people. I think the reason we don't offer it too early at the moment is just because we are not sure that it is better than conventional. And I don't think any of my colleagues and people involved in the field will not offer it too early because of money. In fact, you could argue the reverse. In some countries, some people may be tempted to give it early because if you're paid by what you do, if you do ECMO, you get more money because it's a more expensive intervention. But even colleagues in those countries, the one we're dealing with, certainly don't do it for the economic aspect of it. The only thing we do is to avoid putting people on it who will not benefit from it, because then indeed we recognize immediately that not only the human cost, but the economical cost will be astronomical for no good reason.
I could talk for a long time on the issues with financially incentivized medicine, but I won't in this context. And I think I'd perhaps like to draw things to a close, because I appreciate we've been talking for quite a long time, by looking towards the future and really asking you again. I'm sorry for the broad questions, but what advances are you excited for? Changes are you excited for in this field?
If you ask me the future of ECMO, my answer would be that the best thing that can happen is that you never need ECMO again. Because what we do with ECMO, we support people, and during that time, we treat them. If you get very good at treating them, if you pull the arguments, you should not need to put them on ECMO, because you understand the pathophysiology and you can act on it. And therefore, ECMO becomes a non-entity. It's a non-requirement. ECMO is just a support. And I mean, that's the way I define a good ECMO service. It's a service that beat itself when they use ECMO because they had to use ECMO because everything that's been done before was not successful. And so they have to introduce what is these days one of the, in our field, cardiorespiratory, the peak of the support, if you want. In terms of the future, it's to be able to have a system that don't introduce morbidity and mortality, but then that's not the ultimate goal, because you have the problem that you would end up, as we just discussed, with people sitting on ECMO with not a chance to recover and nowhere to go if they are on it. So I think the best future of ECMO is that we don't need it anymore, because you've learned to treat your patients better and you never need to implement it.
I guess the counter I would put out to that is, you might end up, if you better treated one cohort of patients, as I think I heard it first in talking about anaesthesia, you end up going after sicker patients. So the patients who are treated with conventional therapy who may no longer need ECMO, but you might be better treating some other patients who might survive as a result of it and still require ECMO.
But you're not treating people. So the only thing that ECMO would then do is to support sicker patients for treatment to help them. ECMO doesn't treat, ECMO supports. So you're right. I mean, if might be the future that we shift to supporting sicker patients to get them access to treatment or to try new treatment or to progressing. But again, the difficulties, the risk that we have if you do that is we end up by the sort of prophecy that you cannot die without ECMO. That because, I mean, we still all die because our heart stops. Let's go with that. Let's forget the brain for a minute. As you know, I work in Papworth, so the heart is more important. But if your heart stops, you're dead. If you got ECMO, we can just keep pumping for you forever. But the forever doesn't bring you anywhere.
I mean, that's one of the ethical challenges, I think, of the modern intensive care unit, in that we can support more and more vital organ functions, even with whether it's with ECMO or dialysis or even transfusions, replacing the effect of the bone marrow. And to what extent, yes, is that really meeting the goal of modern medicine, which I think comes back to the very simple. It fudges the the classic adage of we want to make people live longer and live better, but because living longer is not necessarily the aim within this.
Correct. I mean, ECMO support is only successful if it allows people to live better. That's the only thing. I think the longer is only there if ultimately it's for a better outcome.
And I have to ask this as a final question, because I've been involved in a little bit of research relating to patient experience in ICU and following surgery. What's it like for patients to be in an ECMO unit, and how perhaps does that care compare to other intensive care units? And can you see anything you'd like to, I guess, improve here or change here? Or
I've never been a patient on ECMO, so it's probably unfair to answer on their behalf. On the clinic we run, and it's run by one of our consultant nurses, one of the key findings is that most of them don't even remember it. Because if you take the normal run, the non-COVID run, they can be short and quick. So patients will be, imagine in, let's say you're in Ipswich. So in Ipswich, be put asleep because they are unwell, be then on conventional support. Then they go worst. We go to pick them up, put them on ECMO, bring them to Papworth, support them. Their lungs get better. If it's respiratory ECMO, we then remove the ECMO. We then move them back to Ipswich, and they wake up in Ipswich. And they don't know they've been in Papworth. In their mind, it's not there. What we've picked up at the clinic is that for those patients before COVID, and specifically respiratory ECMO, the normal short run one, it's the relatives, it's people who were alongside them that have PTSD and so have suffered much more, because they've seen them being dead or dying or being taken to the extreme of physiology and then coming back from that, while for most of the patients, no action. I always remember this patient years ago who had a PO2 of 4 kilopascal for days on, and at the same time was hemorrhaging from a rectal bleed. We never thought she would survive. She spent weeks with us. It was quite a difficult management where a lot of things happened. And then she survived. And she popped back a few months later and had a quick chat with her and asked what she remembered. And she said, it's funny, the only thing I remember from Papworth, it was a absolutely supreme experience. And I was convinced all the way along that my family had been paying for a special spa that was never ending, because I was pampered and looked after all the time. And I've got absolutely no bad memories. And she was absolutely fine. Her family wasn't, because they had seen her going through all that, and they'd seen her going so unwell and so sick. She had absolutely no recollection. But we have many other patients who are awake on ECMO, and I cannot answer for them, because how can you be sitting on a machine in a chair, highly depending on the plastic and the pump and the oxygenator and the people around you who do everything for you, they even breathe for you, and really share your more intimate feelings? Can you do that? I don't know.
Well, I don't
You
think I
remain
can
your own
answer for
person.
that. Well, I don't think I can answer for that. I can't answer for that either. And I think probably that is another, unknown for us that we can use to end this podcast for today. So thank you so much for speaking with me. It's been a really, really interesting conversation.
Thank you. I hope it was interesting, and I hope that you can make something out of it.
Thanks for listening to the Page Podcast. As ever, we'd love to hear what you think. So do leave us a review or rating on Apple Podcasts or Spotify. And you can get in touch via Facebook, Instagram or Twitter, or email us pagerpodcast@gmail.com. Bye for now.